Good morning, everyone. We're going to give it a few more minutes. Apologize, I'm going to stay off camera today. I'm feeling a bit under the weather. Joy, do you know if Ryan is joining us today?
He is not. He's down at the Capitol for the Legislative Oversight Committee for the Behavioral Health Disorders in the Criminal and Juvenile Justice Systems.
Oh, yes, that the big long name one.
Yeah,
Need to come up with more creative names, or at least a way to give us a good acronym, right?
yeah, no doubt.
I know that's where Samantha Garrett is also. We've got several people on vacation. I suspect this is going to be a very short meeting. Michelle, would you like to kick us off? Michelle, are you there?
Sorry, my screen was so low, my audio and video was not visible to click off of. Yes, hi, good morning.
Good morning. Yeah, no worries. I was just like, maybe she
Good
logged in
morning.
and then went to go grab a cup of coffee. Like, you know,
No, I couldn't find my buttons. Couldn't find my buttons. Anyway, yes, small meeting, short meeting, lots of people out. So 10:03. You've got the agenda pulled up. So our board members, meeting call to order. Let's look at board members. We have Joy, Jessica, Taylor,
I was
four.
gonna say, Joy is not a board member.
No, yep, and that's what I was just reading. So there's only three of us.
Well, we have some new board members, which is what
Ah,
we're going to get to next. So we have Donna Pinson from Children's Hospital joining us. She is a new board member. We also have Sean. You're going to have to remind me, Sean, where you're from.
I'm serving as myself, someone who's a consumer of mental health, but I work at Denver Health as our CCBHC lead evaluator. So have some knowledge from the data side and everything going on over there.
beautiful.
Fantastic. And it looks like we just had Tiny join us and we just had Jen join us.
Beautiful. James, where have you been? We've missed you.
Yeah, guys, I'm so sorry. It's good to be back.
We've
That's a sweet goatee.
Yeah, no kidding. We've missed you. Okay, so um, can we just, Donna and Sean, would you give just a couple minute kind of overview of your background and why you wanted to be part of this world that we sit with? Would love to get to know you.
I don't mind going first. Good morning, everybody. Donna Pinson. I am a nurse by background.
I've been at Children's Hospital for going on 12 years. I've been in accreditation and regulatory that entire time. I currently serve as the director of that department. About 5, 6 years into my career at Children's, I took over all of the reporting and working with our Pediatric Mental Health Institute on all things accreditation, regulatory policies and procedures and so on, and became very invested in the mental health work and this patient population. And so when I was asked to have the opportunity to do this, I jumped at it because I'm very passionate about it and want to be part of the healthcare that these kiddos receive, specifically to children's, but in the community broadly as well. Like I said, nurse background. My background was not mental health; it was labor and delivery back when I did bedside nursing. But once, like I said, when I came to Children's, got into this work and really, really enjoy it and being part of it. So, anything else you want to know?
No, that's beautiful. Thank you. Thank you. Welcome.
Thank you.
And I missed Kelly before. Sorry, Sean, before we have you go, just want to say, I missed Kelly. She's a new board member, but Kelly will introduce herself also right after Sean.
Hello, everyone. My name's Sean, he, him pronouns. I am from Colorado. I've lived in the state my entire life. I think I was first diagnosed with major depressive disorder when I was 11, and I've had my own experiences with SI and a number of different things. Some friends unfortunately passed away in the opioid epidemic. So mental health is something very near and dear to my heart. I went to school for engineering and then ended up at Denver Health as a biostatistician and data scientist. So I feel the work I do, I couldn't be on the front end with clients because I would just start crying, but the work I do is meaningful in helping folks who are unhoused or suffering from mental health or substance use disorders. Right after I joined Denver Health about 3 years ago, I was the one who got us through our CCBHC accreditation and wrote the entire thing. So I have painful knowledge about all the rules and regulations for that, and I help do project management for that grant. I also help with the community advisory panel we have for it, of which Kelly is a member. So it's very good to see you here, Kelly. And mental health is probably my number one passion. I'm an outspoken advocate for it. With personal experience, friend and family experience, and the work I do, it's a huge part of my life. So I'm happy to be here to provide feedback from various different sorts of perspectives, including kind of the data side as well, and regulatory. So I don't know if there's anything else you'd like to know, but just happy to be here and get a chance to work with you all.
That's beautiful. Thank you. Thank you. Kelly, welcome.
Hello, I'm Kelly Komkowicz, and I am not a consumer of mental health, but I am the parent of a daughter who was a consumer of mental health care before she committed suicide in 2023. So I know all of the many ways that it can go wrong. We were involved with lots of different systems, and all of them pretty much failed her. So after her death, I actually put in a complaint to BHA and was told that no rules had been broken. So I'm on a mission to make sure that the rules are changed so that the things that happened with my daughter are things that can't happen again. And if they do, there is a rule that has been broken. So I'm very interested in making sure that the rules have changed, that there is care out there, that it is compassionate, that it is effective. And so I'm really kind of that's my goal. And I've been looking at BHA rules for a really long time, a couple of years now, because I really care about this. I am passionate to make sure that this does not happen again.
Yeah. Thank you for sharing all of that, Kelly. I'm so sorry for your loss. A daughter there's no words. There's no words. But we are over the moon that you're here with us. We have some great conversations, and we work really hard to make some of the changes that we hope you'll agree with and help us with moving forward. Those are our three new, Jessica.
That's what I see in our list. Anybody new that's joined us today that we're missing that has been appointed as a board member? This is our list. So we have a few people who have been reappointed, Michelle and Dr. Rice. But these are our new folks down here towards the bottom.
Can you send that to me, Jessica, so I have it in my file too?
Yes, it's also linked in the agenda.
Beautiful. Oh, even better. Okay. Fantastic. So,
I'm actually going to come back.
and you said all of the board members are listed there because we had some drop off, right?
So
Kathy?
these are the ones that were reappointed or appointed this year. So anybody that's an existing board member, like myself or Jen, who are not up for renewal, are not going to be on this list.
I just want the whole list in one place. I'll
I
go find it.
think, not going to go down that way. It's
Yeah.
got some private information there. We can send that out. We have an ongoing spreadsheet that we can share
Okay, perfect. And
with
I'm
the
sure
other board members.
it's in my email, I'm sure.
I don't think we fully updated it with all the new appointments, but yeah, we'll get it. It's on my to-do list.
For the days that I have to go, do we have a quorum? It helps if I know. Make sure I have a list to attach to when my brain is foggy on a Friday.
Well, let's see. I don't think we do have a quorum today. We've got 1, 2, 3, 4, 5, 6. Katie, you're not a board member, are you? I'm agreeing with you, Michelle. I need a list.
Yeah, I just need to be able to quit because again, I know Cassie dropped off. James, are you still on? I thought James dropped off.
No, I dropped off.
Okay. All right. See, I don't want to count people. I'm so used to counting you. I don't want to count people like not legally able to count.
Yeah, no, Ruben Farnsworth is he was my recommendation for taking my spot. I just don't have enough time to promise to be here every month. I try and then I always get pulled away.
Sure.
And I just felt so bad. I think the work that this board does is so important.
For sure. Katie is a board member, so we're at 7. That should be quorum.
I was going to say, I thought Katie was a board member. Okay, we need a list. I need to stick it on
I'm
the
sorry.
computer. 1, 2. 1, 2, 3, 4, 5, 6, 7. Tom is not. Yeah, there is 7.
All right. Call it quorum. I apologize to the board and to other members of the community. I do not have the June meeting minutes for us to approve. Just have not had the ability to sit down and sit with that recording and take those copious notes. It will be very similar to what the May meeting minutes looked like because we worked so hard on the innovative ideas. So it won't be too different. So we'll have those for approval at the next meeting. I apologize.
Perfect. No worries.
So another thing we wanted to discuss was time and location of our monthly meetings. I know there's been some discussion that these Friday mornings are a bit burdensome for some people, people who don't work Fridays, or just like the cadence of them is not conducive to what we want to do. So opening it up to suggestions of how we would like to continue these moving forward, given that we're in a new board year.
Yeah, I think I brought that up just because last year we kind of struggled with having a quorum, probably a majority of the meetings. So I just wondered if a different day would be better for folks.
For me, any day other than Friday would be better.
Yeah, okay.
Wednesday mornings?
So I personally have like daily rounds at the hospital every day. Let me see. You said Wednesdays. Does Wednesday work for most people? Same time, 10 o'clock?
Wednesday, I have standing, well, at least on the 4th Wednesdays of the month, I have standing COPA meetings for the state. So Wednesday's out for me unless it's 11.
What about Tuesdays?
Tuesday's good for me. I don't have a lot of meetings on those days. I'm pretty flexible.
Tuesday's open for me.
I can do
Tuesday's probably
Tuesday.
better.
Yeah, so I can do Tuesday mornings as long as it's not the first Tuesday of the month. I have a standing internal team meeting.
Dr. Rice, are you available?
Yeah, no, I have executive meeting every Tuesday, and Wednesday I have medical team meeting. So honestly, if it's any day other than Friday, it's going to be really hard for me. But Tuesday and Wednesday's definitely out for me.
Thursdays?
Thursday afternoons. I can't do mornings on Thursdays.
Thursday afternoon works for me.
I can't do afternoons. I can do any morning, just not afternoon.
Okay, how about this? How about I will work on sending out like a doodle poll and people can put in their availability and then we'll get it narrowed down to like 2 options and then we'll select it at the next one. But we'll plan for like the next meeting being Friday and last Friday of the month. Does that work for everybody?
Perfect.
It'll be the 22nd next year, right? It's the 4th, Friday.
Yes.
Okay.
The 22nd of August.
Mhm.
Let me double check that.
Okay.
That is the first day of class I teach, and it's a 3-hour class. So I can reschedule for other Fridays. That Friday I cannot.
That's totally fine. We will figure it out.
Okay, perfect.
I say, and we usually have our Caitlin, and is Caitlin Long? I'm sorry, I'm also under the weather today, and my brain is just not working on all cylinders. But she has a whole list of bylaws that we have created as a group, and she's finalized that talk about like how many meetings you can miss. And so missing a single meeting is not going to put like your membership with the board in jeopardy. So it's okay if we have occasional conflicts.
Did she send that out, or do you have that, Jess, to send to all the new people? There was a new board member packet that we had created.
I have access to the folder that she created, so I'll look in there and see what I can find.
It should be there because it is finalized, and you could send it to these 3 new folks.
I can do that. All right. Michelle or Jen, you want to take on the next section?
All right, so innovative 2765 ideas, just to get the new folks up to speed. In the past, if we as a advisory board want to make recommendations on rule changes or even statutory changes, we draft a letter. And so we have been in the process of drafting or coming up with our priority initiatives, sort of our top choices for what we want to get done throughout the year. And one of them is a recommendation letter. So we have been working on that for the past, I don't know, 6 months or so, maybe. So that just kind of gives you an idea of what our recommendation letter is. And then I think every meeting we should probably go over our priority initiatives and kind of touch base where we are, if we've completed things, that sort of thing. So that being said, do we want to go over the letter that we have so far?
I was trying to unmute. I don't believe we've started the actual letter. We have our innovative ideas and we can pull that up.
The draft. Yeah.
There we go. That's what I was thinking of.
Yeah, we need to start having the conversation of how we want to draft it and which ideas we are going to be sending our recommendations. And the recommendations, we got some clarification from Ryan Templeton that this recommendation letter goes to BHA.
Really quickly, when does the ASAM changes go into effect?
There will be some official communications coming out, but there has been a different date, and I don't Oh, Tom's here. Tom, would you like to speak to that?
Yes,
Just
this is a kind of a late game time development. Actually, before I continue talking, why don't I introduce myself? I think there's probably folks that I haven't met because there's a few new members. So, Tom Miller, I am the division director for the Quality and Standards division at BHA, and so Jess and I work together on the Quality and Standards team. Generally speaking, Quality and Standards does the licensing, designation, and approval of all behavioral health facilities in the state of Colorado. We have the enforcement unit. We also have the regulatory unit located within the division. And that's why I came today. I anticipated a question about ASAM because it's the regulatory unit that's doing those rules for the change in ASAM, along with a lot of other regulatory changes. So the plan had been for ASAM 4.0. There's a new edition of ASAM coming out. Well, it's already out. And lots of other healthcare systems have already adopted it and predicated their billing and service delivery models to the fourth edition of ASAM. And we need to change our system, and in particular, our regulations to operate in adherence to that. The date that we had set for that was July 1st of 2026. And we were working directly with organizations and also starting to draft our rules and do some community engagement for those rules. And I think as a result, this is primarily as a result of healthcare policy and financing, hearing directly from providers that they were concerned about the pretty massive changes that they would have to do, not only personnel wise, but perhaps physical plant wise, also to accommodate withdrawal management within their service delivery models. HICPUF worked with SAMHSA to say, all right, what do we have to do to delay the implementation of ASAM 4.0? And if you want to hear the nitty gritty, they have to send an update, an official update to SAMHSA about delaying it, which they have done. And it's my understanding they have received approval to back up the implementation of ASAM to July 1st of 2027. So we've drafted a joint agreement with HICPUF. Commissioner Smith approved that yesterday. Director Bimsteffer approved it, I think, the day before. So we're hoping to get that out today, perhaps very early next week, so that we'll have systemic notice that we're backing that timeline up. On the Quality and Standards team, we've reached out directly to some organizations that were most affected by that, and we're going to continue to do that individual communication. So that hopefully that's a comprehensive response about ASAM, how it happened, and what we intend to do in terms of communication. But Michelle, any other questions directly from you or any other member?
No, not at all. I was just curious on the timing.
I recognize that it could be awkward for those organizations that have been hurrying up to make sure they met the July 1st, 2026. What I'm hoping, and I hope that this feels this way to those organizations, that none of that was wasted work. We need to get the work done anyway. What we've done is given ourselves a whole additional year to make these pretty comprehensive changes. And I hope that that prevents what I think would have been the absolute tragedy with this, is that any organization has to stop providing that level of service, or even worse, go out of business as a result of additional physical plant or personnel requirements. And I'm hoping that this additional year gives us time to build it. And this is maybe just a little bit of my own personal perspective. Understand more about what the state and federal budget changes mean. for all of us and figure out paths forward as a result of that. So I am thrilled about the additional year that we have to make these changes.
Fantastic. Thank you for that.
Thanks for letting me chime in. Any questions from anybody else? Thanks, Jess. Anything that you wanted to say in addition to that?
Just kind of something that Kelly had said. I mean, with these ASAM changes getting pushed back, we are still looking at revisions for Chapter 11. And so one of the things I can do is I'm going to drop the link for rule feedback in our chat so that everybody just has quick access to it. It's also available on the BHA website. So if there's like specific rules that anybody wanted to address and have some opportunity to provide feedback, we will be taking that this whole time.
All right, should we go through our list and just kind of let the new members review and see if they have any questions or additional feedback?
Yeah, and just to let new people know what we've done is what is the numbered things that you see are the ideas that have been posed by different people over the last year, and then we've pulled them back up and we've gone through and we've rated them. You'll see in the red as high, medium, or low priority. But that priority is based on two things. Number one, how important we feel the topic is, but number two, how easy we think it might be achievable to actually make this change. Because some of these things will require fiscal notes, statutory changes, legal changes. And so we're taking all of this into consideration, just as a little disclaimer.
Michelle, do you want to do just a quick overview of each one and how we got to the decisions that we've gotten to?
Yeah.
Or Jen?
Go ahead.
We'll alternate them, Jen. I'll do one, you can do the next one. We started with automation of M1s, and this pretty much came from the idea that at a state level, when we report out on how many M1s have taken place in the state in a certain period of time, that number is wholly inaccurate because the number comes from the number of individuals on an M1 that land at a 2765 facility. So, for example, a physician in an ER who receives someone who is a walk-in can place them on an M1 hold, call for crisis, have crisis come do the assessment. And if crisis ends up safety planning with that person, the M1 is rescinded and the safety plan is moved forward with. But what this means is we don't really know across the state how many M1s or individuals have their civil liberties taken away from them in a year. We only know the number that make it to the facilities. And the BHA has started, uses the data that comes from the ERs to say how many M1s have you done. But what we would like to do, because it also doesn't account for M1s done by law enforcement in the field and then rescinded when they get to the ER, we had talked about how could we automate M1s. So this was one of the innovative ideas that came up last year in a conversation. We put it on the list and we've now revisited. We've talked about where this could fall, higher, medium priority, low priority. And the pink are some of the comments and conversations we had around it. And then we deemed it a high to medium priority because we feel like we could actually move this forward. So that's the first one. Any questions, comments, thoughts, additions to what's not written there that we might be able to add?
Yeah, can I add just this would also allow for us to get that client level data so that we can see any individual that has multiple holds.
Yes, yes. Kelly.
I had some questions on this one actually. When I was looking at because I read this last night, so I'm wondering, there's a concern about misuse of M1 holds. Can you clarify a little bit about what actually the concerns were there?
It wasn't necessarily misuse of an M1. The individuals who are signing M1s are the authorized signers. They have the ability to sign it. However, um, in some areas, like I live in a very rural area, in some rural communities, a physician who does their initial screening can deem this person meets criteria for an M1, but they do want a more thorough evaluation that's conducted. So they have contracted crisis clinicians who will come in and spend an hour and a half with that person, call collateral, research their history, call their therapists, their psychiatrists, and they may actually say, you know what, yes, they meet criteria for this M1. However, they're willing to go back to see their therapist. Their therapist has an opening this afternoon, and they are denying being suicidal with the hope of getting into the next step of treatment. And then that M1 could actually be rescinded. So it would allow, if things were automated, it would allow for that type of M1 to be captured. If a police officer in the field needs to take someone in because they are not qualified to do an assessment, the only legal way for them to transport, not the only legal way, but one of the legal ways to transport them from the field to the ER for that assessment or to the walk-in center for that assessment is to fill out that M1. But the same could hold true. They get to that final destination, they have a thorough assessment by an expert in the world of crisis assessments, and they deem that that M1 is not something that needs to take place because we're always looking for least restrictive levels of care for the best treatment. And so that M1 could be rescinded, and that M1 would then not be captured in the overall data for the year. So that's what we're trying to look at, is how to actually capture the number of times somebody's civil rights have been removed because they've been placed on one of these holds. That answer your question?
It clarifies somewhat. I think this connects also to the later material on here. I did listen to the meeting from, I believe it was February, was your most recent one that was posted. And there was some discussion about law enforcement not wanting to pick up people on M1 holds or on even higher level holds, and transport because of a fear of being liable. But I also noticed that it seems that there's a disconnect, I think, in some places that the M1 holds, and that's why I was wondering what was meant by misuse, is because M1 holds seem to be used only for extreme and immediate danger and not, and very rarely for gravely disabled. And so I'm wondering, like, if there's anything around that so that there's maybe even in the automation of an M1 hold, you could have a designation where there's a separate category for, immediate danger and gravely disabled.
Yeah, and the misuse, just to explain that misuse, and I don't remember, forgive me, the exact conversation, but the when we talk about misuse, let's be really, really clear that we don't say people are out there misusing this form and willy-nilly taking people's rights away. But for example, in the world of law enforcement do not have to use an M1. In fact, the M0.5 was created for law enforcement in particular, and it's a transport order, which allows them to put someone on a hold for a lesser period of time, which is the 6 or 8 hours or 14 hours, however you want to gauge this form, but it allows them to simply transport the person for that higher level assessment. So when we talk about misuse, oftentimes law enforcement will use an M1 when they could use a 0.5. When some of what you're talking to lends to some of our bigger discussion, and you might find it down farther, but there is a really big push we did about education on M1s. Because suicidality is pretty cut and dry in the world of crisis. People know how to assess for that. They know how to look for that. Homicidality is pretty cut and dry. That grave disability piece is a little bit more gray. And you do have to have a lot to stand on. And so I think people do shy away from that a little bit more, because that it's a little more murky. But I wouldn't say that it's not used. Um, and I would say that sometimes that is misuse. Like, for example, a police officer will put someone on an M1. I've shown up to the emergency room and they'll say, well, they were homeless. And I'm like, well, homeless doesn't equal gravely disabled. Um, and so this is where our conversations have been. Does that help a little bit more?
It does. Just on the opposite side of that, we were begging officers to take my daughter
Yeah.
in, and they wouldn't.
Yeah. Yeah. And again, they are ever since 2020 with the whole defund the police movement, law enforcement's very skittish. They're very, very skittish. And that's why we've tried to put measures in place that take that liability away from them. And I know I personally, and most people on this call can speak to being with a police chief or a sheriff who says, absolutely, my people can do this. And then you'll walk and meet up with one of their deputies or officers. They're like, I don't care what they say, I'm not doing it. And they have the right to do that because it's a civil order, not a criminal order. And they can walk away. Yeah. These are all the conversations you will now be looped into. Jessica.
I was just going to touch on the grave disability piece because we do track how many grave disability M1 holds we get. Typically, the grave disability is attached to danger to self or others. And the reason you're going to see a lot of that immediacy needed for the M1 is that's how the statute is written, right? You have to have an immediate danger to self, others, or grave disability, whereas the threshold for certification is a little bit lower, where it's like substantial threat to self, others, gravely disabled. So if that's something we wanted to explore around the statute language, we could absolutely do that in this meeting. But I know there's a lot of advocacy groups that really want to make sure we're careful around taking away people's civil rights for things that are not immediate. So I hear it on both sides is all I'm getting at.
All right, moving on to our second, combining the emergency commitment and the M1 process. I've been on this board for, I don't know, several years, and I will tell you that we have been discussing this for, I think, since I started on this board. Currently, we're going to put a pause on discussing this really further just because we want to wait until these changes take place. But the biggest piece of this one is that they're very different. There's different facilities and just very different processes. So I think a bigger piece is educating folks that they are a different legal commitment. But again, this one is one that we're just kind of, it's out there, and we'll continue to touch base on it, but we are pausing until these changes go into effect. Does that make sense? Any questions?
I just have a comment. When I was at the ASAM conference, it was really interesting. They, um, like, there's so many variations state to state on how they deal with this situation. So, I just think if we revisit it, we have plenty of examples to look at from other states, and I think the fact that it's like there's so much variability kind of speaks to like, what is the right way to do this? I don't think there's a clear consensus. But it was just really enlightening to me to hear like all the variations on how this happened. So just food for thought when we tackle this one.
Any other questions, comments on ECIC and M1? Okay.
Training. Oh my, oops. training on pickup orders and clarification of statute of who can provide this response. This has, if I'm not mistaken, this was big discussion, but from this discussion, we invited folks from that really long named group of criminal justice, the one where Ryan is sitting today at the Capitol, but they are a subsect of another group really focusing on pickup orders and transport. And because they are meeting weekly, they are working with some of our state representatives. They have a judge who has put forth some new language to be considered. This whole conversation we have kind of paused on because they are taking it and running with it. Some of us do go to that meeting as well, just so we can stay in the loop of all that conversation. I've actually been asked to meet with two of the state representatives about some of the conversation that came up at the last meeting. This is a huge conversation, and it might be one better handled by them. So if we put this in our recommendation letter, we would just want to reinforce that we are working with them and others to help move this topic to a resolution. Am I missing anything? Anyone else see this in a different way?
No, just historically, for new folks, we started discussing this. It's even if a patient is on an outpatient certification, it's really difficult to get law enforcement to pick these patients up. We all know that if SPMI patients miss their medications, miss their appointments, that's a really big red flag. But sometimes law enforcement will say, I'm not going to go take away somebody's rights because they missed their medication or missed their therapy appointment. So that's sort of where this started. Not to mention the county barriers, especially in the metro area where across the street is a different county and law enforcement will only pick up in their county.
And that group is moving full steam ahead. Just in case anybody else is able to attend that next week, Joy jumped off. I know Joy used to go to those. If anybody is able to attend that one next Wednesday, just to bring this group back, the information that I took from this group. So when Dr. Rice was talking about her visit to California and the team that she was with, where she saw them go out and pick people up and bring them to their appointments, I did bring that as asked to that group. And as you can imagine, it stirred quite the pot and spurred lots of conversation. And that conversation is now moved into a lot of side conversations and investigation of material, and conversations with teams that are doing these things. And in a nutshell, this group was trying to figure out how do we make law enforcement more comfortable to do this? And it has now shifted in, and then it started to shift in, can we include crisis and EMS in picking up these folks? And then with the conversation that we had that one day, it shifted to, well, maybe there's an alternative to even using law enforcement to pick up these folks. Let's explore that. And that's kind of where it stands now. But if there's anyone who can attend that meeting next Wednesday, I do not know if I will be able to. I will be traveling. I'm going to try to catch it in the airport just to listen.
Ellie, did you have a question or a comment?
I did. I'm not sure what the rules are, whether we're supposed to raise our hand before we say something, but I'm like, I just keep raising my hand.
Go for it.
So I had a question on that in terms of the picking, because I was reading through that, and one of the things is talking about, restraint of force to pick up the homeless population or the mentally ill on the streets. There was just recently there was a federal executive order coming down from the Trump administration on ending crime and disorder on American streets that directly requests that the police do this, and that there's funding attached to it. I'm just like I'm wondering if that's under consideration in connection with this, or just wondering where that's standing.
I can speak to that. Or Michelle, do you want to go?
No, go ahead.
That just came out yesterday. I can try to find a link to one of the articles. It's not related. I think it's very similar to what happened in New York City with Eric Adams trying to just basically take people's rights away and put them into facilities. But the bottom line there is the feds actually can't control, and anyone correct me if I'm wrong, um, like how states involuntarily commit people. So it seems like it's just a bunch of hot air right now. But definitely, there's this whole drive to, the solution to this all these very complex problems is to basically reinvent the state hospitals, and there's no funding for that anyway. So it was definitely concerning, I think, to hear it, but I don't know what's going to come of it. And I'll try to, like I said, I'll try to find something and put it in the link.
Yeah, I remember reading it, and I same don't know what the link is. The other piece, again, when you think about the holds, all of us on this call, in fact, we should probably do that for new people, unless there's another new person starting. We should probably all introduce ourselves on the board and where we come from and who we are. But we all represent different areas, and that's the other beauty of this group is where one person can see the need for picking this person up. We also see the flip side to that but there's really nowhere for them to go. And now they land in the ER. And when they're not needed nor wanted in the ER, the difficulties that poses. Okay, can we use this place? And so this group talks a lot about systems as well as the 2765 focus. We talk a lot about how the systems are impacted. But like I just said, a police chief will say, yes, my people can do this, and the individuals are not mandated to have to do it. So regardless of what comes down, no one is mandated by law to do anything. Any other questions, Sean?
Yeah, and I, like Kelly, am figuring out kind of my role here and whatnot. But for this one, I have a few different ideas. I know at Denver Health, we have teams like our ATOP team and the STAR program, which are great. They have mobile units and they go out and meet people in the streets with caseworkers, social workers. The peer groups can be great, though they aren't clinicians, so there is some difficulty with that. But these are great ways to approach folks and give them different solutions that isn't just bringing them to a facility and professionals who work in mental health care. So I think there's lots of options for that route and kind of, not needing to involve law enforcement, especially for the ones that aren't as critical. And on the flip side, my mother actually works for a crisis intervention training company. They work with Jeffco Sheriff's Department and a number of others. They're professional actors who will role play scenarios of people who have SUD, mental health, a variety of different issues, and they train the officers how to de-escalate, non-violently and how to handle these individuals and whatnot. So potentially there is some ability for law enforcement to receive similar training to be more comfortable in handling these sorts of situations, and knowing kind of how to approach them. And those are just kind of some right off the top of my head sort of ideas, but this is something I have a number of thoughts about and would love to, continue further. Also for the meeting next week, what time?
It is Wednesday at 9 a.m. and I can put the link in the chat or connect you with Kevin so he can put you on the list if you would like to just get reoccurring meeting topics. They're great to listen to. And again, I would encourage anyone who jumps into a new meeting here, spend a lot of time listening because there have been lots of conversation and it can get kind of tense. It can get very tense. But it's great to listen to where folks have come from. But I'll send that to you, Sean.
Okay, I should be able to attend, so thank you.
And in regards to what you said, so I wonder if your mother is one of the actors for CIT. So CIT around the state goes around and teaches law enforcement all about mental health, and then they do the role playing in the afternoon of the 40-hour workshop they do. Many of the officers in the state are CIT trained, and just as a note, Post is redoing all of their education for the officers who go through the academy, and they are making it much more structured, and there's going to be a lot more accountability in making sure that each of the post academies in the state do much more similar education. So that is happening. And then the second piece that you talked about with Denver Star, yes, in talking to the folks at Denver Star and other teams around the country who go out and do this, one of the biggest things that this talks about with for us is if a court order is written by a judge, this is part of what we need to talk about is it states that they must be picked up with secure transport, i.e. law enforcement. So if we don't want that, we have to change some of this. And so therein lies all these conversations is because they involve statutory changes. Did I misspeak or misstep or forget anything with that? My BHA folks? Okay.
See a thumbs up, but thank you,
There
Michelle.
you
Yes,
go.
she does work for CIT.
I think
Yeah.
we're good. I think we're good. Yeah. I mean, that's literally what all these conversations are about is can we change the statute and the language if we can get people in place who are willing to do this? How do they get trained to do this? So it's this big step forward. And I think that's why so many people in so many different pockets are talking about it. And this, if anyone knows the acronym, toss it in the chat. It's the Criminal Justice, so the CJ of Behavioral Health, BH something something transport group, and that's what they're working on. So we're gonna let them take that and run with it. We got other stuff. Okay, so then the next one.
So this one we were discussing a way to have all courts and districts on the same page with 2765 rules. For example, so I guess I'll just tell you my background. I work at the Fort Logan State Psychiatric Hospital. So we take patients from every county in Colorado, including the rural counties, and our experience, I work in the admissions and legal department. So we see every cert that comes through our facility, and what we've noticed over the past, I don't know, maybe 5 years is that each county sort of has their own rules and specifications. For example, Denver requires 45 days to petition for extensions, whereas other counties do 30. And then some certifications, they put that they're in order for 3 months. So, September 6th through December 6th, whereas other counties count 90 calendar days. So it might be September 6th through December 4th. So we were just making a conversation about how to get all the courts on the same page. Because I'm sure we're not the only facility that handles certifications from all over the state. Any questions, comments? Did I miss anything? Okay.
So then this was where we left off. This would be our next topic to discuss. What people think, whether we should give it a high, medium, or low rating. But this is about funding enhancement and incentives for designated facilities for providing care. One of the things that comes up a lot is the lack of funding and the budget constraints, particularly in this year. It's usually a yearly thing, but particularly in this year. And so we were talking about what are some innovative ideas for funding enhancement? And this was that basic conversation. So we talked about things being paid by court, as a court procedure, how involuntary medication orders and the cost of those medications, where is that cost being absorbed, who is responsible for that cost, who is paying for additional care of individuals, incentives. Someone mentioned the CARE Act of California, and that was something that was used in California to be able to help increase funding. And then we talked about looking for making EMS agencies an essential service. This is something that came up that was a big conversation just after COVID, because it became highlighted during COVID that EMS agencies are not considered an essential service. And so there are certain things that they do not have access to, are exempt from, don't have the ability to do because of that lack of designations. We did talk a little bit about that. Things here anybody would like to add?
This actually was where I was saying that new executive order might be leveraged.
Oh,
That's what I was saying. So on this, that actually from the White House, this is from the actual whitehouse.gov, says the order redirects funding to ensure that individuals camping on the street and causing disorder or suffering from serious mental illness are moved into treatment. So it says redirects funding. So I'm just saying possibly
interesting.
leverage that to
Yeah.
do what we want it to do instead of what obviously it's intended to do, which is to, not be very nice to people.
Can you drop that link in the chat? Is that the same one that Karen?
It is not. She's looking at
Okay.
the article about it. This one's actually from the White House. It's the fact sheet put
Oh,
out by the White House.
all right. And you have to pay to subscribe to the Washington Post.
You do.
You don't have that you don't have that in a PDF form, do you?
Wait, you guys couldn't access mine?
No, it's
Oh
No.
man, no, I got some. I don't subscribe to the Washington Post, and someone sent it to me, and I opened it.
Oh,
Weird.
yeah. No, it doesn't let me even
Oh
to
man,
read it.
I'm sorry, but
That's okay.
I don't have a subscription to it, so my bad.
That's okay. If you can open it and read it, screenshot it and send it to me. I'd
Yeah,
love
I can try
to.
to do that. Yeah.
Anyone else? Thoughts, comments, things we hadn't really discussed this much.
So what are the other, so you're saying you're looking for where the funding and for the treatment's coming from? Is this the concern? And figuring out how to, so is this a legislative thing or is this a regulatory thing?
Truth. These are things that we have been dropping into a list for a year, and I don't remember the nuances on where this came from. These are our list of things that we wanted to discuss. Does this strike a nerve in anybody where they can remember what maybe this? Because I know my part of it was Tiny and I talking about that essential service thing. I had just met with the RETAC, talking to them about it, and they said, good luck. But if we could partner with someone, it would be amazing if we could be designated an essential service. But I don't even remember now why that tied in to funding.
Dr. Race had mentioned the amount of time used on some of these like outpatient certifications and that time wasn't reimbursed.
Yes.
And wasn't a billable service. Like that part came up.
Yep.
I'll turn it over to her.
And I can also tell you in the world of EMS. So again, this other meeting that I'm looking for the link to send to you all in the chat, but this other meeting has a lot of law enforcement. And one of the big things they talk about is if you put someone in a squad car and take them from Glenwood Springs to Durango in a rural part of the Western Slope, you're talking taking that person off shift for about 10 to 12 hours. So that costs them to have another person come in and cover that shift while that person is essentially transporting. So they're talking about that kind of cost. In the world of EMS is a medical service, and 95% of what EMS does is billable, right? They can bill insurance for the cost of the care provided to a patient. If they have an empty truck because they drove from Rifle to Denver, they only have a patient for half that trip. So they're only paid for the transport to Denver. But when they drop that patient off and come back, that is not covered under anyone's paycheck except the service that has to pay that staff. And the ambulance services are talking about we're going to go out of business if we can't get reimbursed. And so some of the ambulance services have gotten the secure transport designation so they can get reimbursement, but some of them have chosen not to do it because it is not worthwhile with the reimbursement rates to even be part of that service. So that's the huge conversation about transport. And so there's just this gap in funding, and no one seems to know where to be able to make up that funding because people will come to the table and do the work we're asking them to do if we pay them to do it, but they will lose money and sink without that funding. Well, thanks for putting that there, Kelly.
Sure. So this is possibly, that's what it says, HICPUF collaboration. So this is going through HICPUF. Is that
Pieces of it can.
okay? And then, all right. So then part of it's going through CDPH. Okay, I see now where you're. Because so this is just for the EMS piece of it, not some of the other parts of.
Again, that's what I'm saying. The EMS somehow, with whatever was being discussed in this, EMS was brought up, and then it turned into this, if we could help EMS, could they be part of this? And the conversation kind of went that way.
Okay.
That's the part I remember because I had had several conversations. That's why I'm saying I don't know if anyone else remembers the other piece.
I love the picture of Trump. Thank you.
Hey, so
I think that means he's watching me and I'm in trouble. Like, I don't know where that came from. That's hilarious. That's what happens if you copy and paste a Washington Post article, apparently.
Huh, interesting.
hey, this is James. I know I'm not a voting member anymore, but on that, could I get a little more clarification on what that would look like or what the question is?
Yes, these were the emails I was sending you saying, we need you, come back. I need your expertise in this conversation. Like I said, I forget. I am absolutely drawing a blank on where this started as a conversation, but there was something that sparked the conversation about EMS and the fact that many EMS systems are not secure transport and they're not getting the secure transport designation because of the reimbursement or lack thereof. And then that conversation blossomed, and it was mentioned that they were not an essential service. And so I happened to be speaking at the RETAC meeting and had some side conversations about that. And they said that is a huge can of worms. We've pushed for that for so many years. It would be nice if we could have that conversation, but it's very complex. But that it was about EMS being able to do some of these transports in lieu of law enforcement, but everybody needs funding, is my recollection. And I feel like I keep talking and I'm talking even though I don't really recall. So please, if anybody else has a better memory than me.
Yeah, I think I can speak on that if that's all right.
Please.
Yeah, so absolutely the problem is law enforcement is an essential service, fire is an essential service. Liquor stores are even an essential service
Yes.
in another way, right? Like
Yep.
you can't have a county without having law enforcement and fire. You can't have a city if you don't have a way to provide law enforcement and fire. But none of them are required to provide ambulance service. So, because of that, they're not mandated to find a way to fund those. So most of the ambulance services in the state, I mean, if you're blessed enough to live in a major metropolitan area, then your city can choose to have the fire department run your ambulance service as part of the fire department, or contract with a large private for-profit, because they have the economies of scale to make it work. Where we run into trouble is in the smaller communities, right? The rural communities, and they tend to not want to fund supplement, because you can't run an ambulance service in a small or in a large rural area solely on transport revenue, because the cost of readiness is so high. The time you're not running calls, but you have to be available, that cost of readiness is so high that what the private insurance companies pay and what the Medicare and Medicaid pay, CMS pays, doesn't come anywhere near. You actually lose money every single time you transport someone to the hospital. And you don't get paid unless you transport someone to the hospital, which sets up a perverse payment model to where if that person just needed some minor medical attention, maybe their blood sugar was low, and so you start an IV, you give them some sugar, you make sure they eat a carb-loaded meal, a high-protein meal, make sure they're set up there, and then they do a release of care. You don't get paid for that. There's no way to bill for that, because that is not a covered benefit, because ambulance service is only a transport benefit. You are only paid when you transport that patient from the in the most expensive form of transport to the most expensive destination. And then to then set up that secured transport piece when you're already losing money on your primary mission. Now, I would argue that it is part of your primary mission, because our goal should be to bridge gaps in healthcare across the continuum, but not every agency sees it that way, and not every agency has the revenue to be blessed with the opportunity to see it that way. So, so then to ask them to say, hey, we created this bypass for the licensure for BHST, as long as you meet the rules, if you're a licensed ambulance in the state of Colorado, then you can actually provide the service. Now that's great. That's another service we can provide and also lose revenue on, which means they're probably not going to do it, because you have to have the cost of readiness. You have to be there. You have to be available. You can't take a resource from your ambulance and take your ambulance out of service to do that transport in a secured vehicle. So the idea, and it's a pretty decent concept. And New York City, by the way, is struggling with this exact thing right now. If you read any of the articles coming out of NYFD, they're actually struggling with it, and they're one of the largest cities in the country. And if that doesn't set off alarm bells for people, the New York City Fire Department ambulance service is in crisis, and that should be scaring everybody. But the thought was, let's make ambulance an essential service and tie BHST into that. So then cities, counties, municipalities are required to find a way to fund it. They can't exist as an entity without that. It's ideal. It makes sense. You can't run a city without a way to protect your people with law enforcement. You can't run a city or a county without a way to protect it from a fire standpoint. Why is it okay to then say, oh, and by the way, loading them up in a pickup truck and driving them 2 hours to a hospital in the middle of a snowstorm without any medical care, that's okay for a city or a county. Also, we're going to make sure that yeah. So that's now obviously the pushback to that is cities and counties and their associations. They're going to be none too happy with that idea, because anything that sets an additional regulatory burden on is going to be pushed back on, and they have very, very strong, powerful lobbies.
Yeah.
So that is the reality. Now, we did one of the other issues that came up is there was a bill last year, and I was wholeheartedly in support for it. I actually testified on it. I can't remember the number. I think it was 1042, but don't quote me on that. House Bill 1042, and it required insurance companies to start paying for behavioral health services, but it excluded BHST. It didn't expressly exclude BHST, but it didn't include BHST. So the only time that we're going to get paid for doing behavioral health secure transport is if it's a Medicaid client. Medicare doesn't pay for that, and the private insurance companies don't pay for that. So, and in most areas, that makes up a small portion of the entire population that we're actually transporting, including ours, right? Not every patient that's transported, not every client that's transported in behavioral health secure transport has Medicaid.
Right.
And so you end up doing a lot of these transports pro bono, free of charge.
Right.
But you accrue all of that cost associated with it. So I think that if I was going to make a recommendation, that's the first thing I would recommend. Now, I will tell you the insurance company lobby has proven this year, in this last legislative cycle, that they are more powerful than just about anything else out there. So they, I know that they won't be happy with that, and it will trigger a reevaluation, and insurance. I forget what it's called, but the State Insurance Commission. I know that's not the name. I'm sorry, I'm drawing a blank. We'll have to reevaluate the entire insurance structure just by making that changes. At least that was the claim that was put out there. But not including BHST as a behavioral health benefit, to me, felt like a huge oversight. And honestly is probably one of the leading contributing factors to the why ambulance services haven't taken this on, because they don't want to take on another responsibility that's going to lose them more revenue when they're just struggling to keep their doors open now. I mean, for Dinosaur, Colorado, their closest responding ambulance is coming out of Utah now.
Yeah.
So because both the fire department and the special district ambulance service shut their doors because they couldn't make ends meet. So, and then the final piece to that is both the House and the Senate unanimously passed the truth in billing transparency bill last year that would have gone away with surprise. I think it was no more surprise billing in ambulance is what I think it was called. Would have done away with surprise billing in ambulance service by requiring the private insurance companies to pay, I think it was up to three times the Medicare rate, which is a fair and reasonable rate for allowing rural EMS systems to be able to cover their cost of providing transport, right? And like I said, there wasn't a single senator or representative that didn't vote yes. It was unanimously approved in both the House and the Senate, and then unfortunately, several days after the legislative session ended, so that they could take no action against it, it was vetoed.
Yep.
And I don't think people understand just how catastrophically detrimental that was to providing ambulance service in the state of Colorado.
And to put that into perspective, as I was having the same conversation with a couple of the RETAC folks, literally one of them picked up their phone and said, I just had this conversation, and they said, and they quote, I wrote it down. They said, we had a $4,580 bill. We get paid 11 cents on the dollar by Medicare. We were reimbursed $503 for our $4,500 invoice. And so to have this to pass so that it is 3 times a rate is what would have helped them. And you're right. This is such a bigger conversation, but yes, I don't think people realize how detrimental that was to be vetoed.
Yeah, and ah,
Good luck to you.
are you
I
there?
know
Can you guys hear me?
it's your whole world, Tiny. I know. Anything else about this?
Yeah, I just have one other point that I'd like to make if I could.
Yeah.
It is my understanding that, and I could be wrong, but I don't believe so. This is the first time in the history of the state of Colorado that a bill was passed by both the House and the Senate and then was vetoed.
Yep. Agreed. I think this is actually the last topic we had on our innovative ideas list, isn't it? It is.
It is. And I know we've got about 15 minutes left. And so I know we were talking about maybe spending the next meeting actually writing our letter. And so maybe we can narrow it down to which two I think are the only ones that we have. We've got like this the courts, and then we've got the automation of the M1. We're the only ones that were like medium high. And so maybe we can agree that those are going to be the two that we add to the letter that we're going to pen for um, BHA.
Sounds good to me.
Agreed.
All right, back to our agenda. There is a mental health advisory board questionnaire and feedback form. I still don't have access to this, so I apologize. I don't have the list. I'll reach out to Caitlin and see if she can make me a co-owner or something. But is there anybody here from the public that has questions for the council? What I thought was going to be a short meeting turned out to be a full meeting.
We always have good conversations.
We do. I appreciate this board so much. Okay, so go ahead, Jen.
I was just going to say, do we want to close out with introducing ourselves to the new members?
Perfect idea.
You start.
Okay. My name is Jennifer Vasquez. I am the public sector seat, I believe is what my title is. And I am the Director of Admissions and Legal Liaison for Fort Logan State Psychiatric Hospital.
Fantastic. My name's Michelle Muthing, and I am the vice chair, and I am also a public sector seat. I am a 25-year veteran of crisis work. I'm a crisis clinician licensed with the state. I recently, up until last year, ran a crisis center up here on the Western Slope. And last year resigned, retired, and now I travel the country and train crisis clinicians. I work with SAMHSA as a subject matter expert with some of their grantees around the country. And I love sitting on boards like this to meet people like all of you. So we welcome you. Jessica.
I am Jessica Bell. I am the Associate Director for 2765 Services, and I am the BHA representative for the board. I will tag Dr. Rice.
Karen, are you there? She may have stepped away. Wait.
Yeah, we'll pass it over to Katie.
Hi, I'm Katie Donahue. I'm the representative for the Colorado Bar Association. Right now, I'm a legal research attorney for Denver Probate Court as of a month ago. And I spent 5 years of my career as the assistant city attorney who handled all the involuntary mental health proceedings in Denver County. I'm supposed to pass it. Who's here?
Dr. Rice, are you back? Okay. Who are we missing today?
We're missing Samantha Garrett. She is at the Capitol this morning. Let me look at my list. So Ruben Farnsworth is one of our new representatives. He is a public or private sector appointee. We have a Daniel, I'm going to totally butcher this last name, Schellinger, who is also a representative of public or private sector. Wanda Island, also public or private sector. They are not able to join us today. And those are our new appointees. And I have to look at our other list to know who we're missing. That's a regular appointee. I
I feel
apologize.
like we had a psychiatrist from university.
Yeah, Scott Simpson.
Oh,
Scott
Scott Simpson. Yes. Oh, and there's Karen Rice. Dr.
Yeah,
Rice.
sorry, they had an urgent situation. They called. Sorry, I was off the phone. I was on the phone for the last 10 minutes. I wasn't with you guys.
No worries. We're just
Okay.
doing introductions.
Oh,
Introduce
sure.
yourself and where you're from.
Oh, me? You want me to go? I can turn my video on too. I'm not that scary looking. You just didn't need to hear me blowing my nose and such. Okay, so I'm Karen Rice. I'm the what am I? I'm the Executive Vice President of Psychiatry and Psychiatric Operations at Clinica Family Health and Wellness. We recently were mental health partners and we merged with our local FQHC, which was Clinica. So we're now just one big merged organization. Hi. Hi to new members.
Hi.
I didn't miss all the introductions of the new people. I'll just keep listening.
Yeah. No, they did theirs in the beginning. And then Dr. Simpson. Yes. Dr. Simpson is with Anschutz, formerly the chair of the ED.
I know he was the former director of PES over at Denver Health, and I work with him a lot on research and a lot of other things. He's very prolific as far as an author.
Oh, he's amazing. Yeah, he's amazing. And he was unable to be here today as well. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So we have 12 total now.
Do we have any more vacant seats?
Does Ryan count in any way?
No, Ryan is not a board member.
I did not think so.
We left 1 or 2 seats vacant so that if we had things that came up or we needed to be really targeted in like a service population that we hadn't already had on the board. So there's a couple of vacancies.
Beautiful. Okay.
Oh, cool,
Have
cool.
last minute comments?
Nope. I will work on getting that poll out so we can figure out new time and place. We will still plan to meet for the August 22nd meeting on Friday. And then we'll finalize our new meeting cadence during that meeting.
I think I am going to miss that meeting. I am traveling back to the Valley that day. I will try to jump on wherever I am, whatever time zone I happen to be in.
Perfect.
But I may not be there.
All right. Chair or Vice Chair, would you like to close us out?
Yeah. If we have no other last minute things to discuss, we will formally adjourn 7 minutes early.
Thank
Thanks,
you
everyone.
all. Hey, Jessica, would
Yes.
you send an email including all the new board members with the old board members just so that I can update my address book and have everybody's email in one place?
I will do my best.
If you remember on a Friday.
I mean, like I said, on my to-do list. It's hard being Caitlin, is all I'm gonna say. We can't do this.
Caitlin, we just need to find a way to clone Caitlin and bring her back.
I think she might be coming back, fingers crossed, but we would have to post the position that she's currently occupying.
Not that you were not amazing, you were just 6 women in one.
I'm so far from amazing in comparison to Caitlin in this aspect. I'm amazing in other places.
Caitlin was She was on fire. All right, y'all have a lovely weekend.
Thanks, guys. Bye.
Bye.